Thanks, team. Good afternoon, everyone. I'm Anisha Koshy. I'm a Senior Associate for Public Policy at NASSCOM. So the point of my talk today is to kind of prime everyone in the audience. I do understand that everybody comes from a different background. I know there are clinicians here. I know there are practitioners. Of course, there are, I also heard that the CMC's legal team is here. Dr. Marman was mentioning earlier. So this is trying to demystify, as if I can borrow a term from the earlier speaker, the regulatory and the legislative implications of health data management. Reasons being, I think over the past 2-3 years, regulations have changed completely. Just not even sectoral regulations, but broadly even parent legislations, like the Data Protection Bill is being written at the moment, the old IT Act is being thrown out and something called the Digital India Act is replacing the old IT Act. So regulations and legislation has been changing immensely to kind of contain the beast that is health data and AI, or just data and AI, right? So I just want to prime everyone on some key regulations and legislation, so the next time you open a newspaper, you're kind of familiar with these terms. That's the idea. I promise to keep the legal jargon to a minimum, but occasionally I'm going to throw one or two in here just to keep things a little interesting. All right, so I'm sure you have seen this slide before. Suresh had this as part of his presentation as well. In fact, we developed it together. NH and the Data Security Council of India developed it together 2-3 years ago. So I'm not going to go back and explain this slide again. The initial idea, or the overall idea, is what is health data, or what is the data that exists in the healthcare ecosystem? You can answer it with 3 simple questions. What is health data? So the types of data. So obviously you have demographic data, identifiers, your EMR, obviously, your historical data, data that you collect from wearables, etc. And then you have, where do you collect it from? So what are your systems of collection, or what are your avenues of collection? Obviously, you have your physicians collecting it in-house, you have your diagnostics lab collecting it, and then you have your billing systems collecting it. So there are a host of systems that collect it, and then what exactly do you use that data for? So obviously you use it to serve your patients, but obviously you also use it for analysis, you use it for tracking different trends in different healthcare standards, etc. So this is generally the ecosystem. I'm not going to repeat that. I'm sure all of the speakers have touched upon it in some version of the other. I'm going to step straight into how we as legal professionals, or we as policymakers, look at how health data is legislated in the country. We look at it in 3 systems broadly. We have legislations, and what I mean by legislations is parent legislations. So these are legacy legislations that come out, let's say, once every 20 years. These are very rarely amended. They're very rarely prescriptive. They are principal level legislations that exist. A classic example would be your IT Act. It's a large piece of legislation that's sector agnostic, that's supposed to legislate all of digital. So those are your legislations. They're parent legislations. 2 of India's legacy legislations are being written right now. You have the Data Protection Bill, which is India's version of the GDPR, and you have the Digital India Act, which is the complete upheaval of the present IT Act. Then you have regulators. So these are folks that enact the regulations or enact the laws in that particular sector. And then you have sector-specific regulations. So in the case of healthcare, you have sector-specific regulations. So for example, NHA becomes the sectoral regulator, and it comes up with regulations and policies. So the reason why I have split this into 3 is because laws and legislations are different from regulations and policy, right? Laws and legislations are larger pieces of parent legislation, while sectoral regulations are these timely updates that happen by the sectoral regulator. So NHA can come out with, let's say, a piece of policy today and decide 6 months later that the sector has completely changed. We want to update it, so we're going to write a new piece of policy or a new piece of regulation. And compliance with that regulation is enacted by that regulator. So this is broadly how we want to look at it. So within health data and health data management, we have some sectoral regulations. Also, we have some parent-level legislations that we have to keep in mind. At any point, if any of these words are going above anybody's head, just put your hand up and just say, I didn't understand, and I will explain it really quickly. All right, so with legislation, we have some, these are old legislations. So the Puttaswamy judgment essentially is where India's data protection regime comes from. So in India, the Justice K.S. Puttaswamy versus the Union of India judgment ensured that the right to privacy is a fundamental right, which is a right that is inalienable, awarded to every single citizen of India at his or her birth. And that is kind of the pillar that holds data protection legislation in India. Back in the day, 2011, we had the SPDI rules which came out, which is the Sensitive Personal Data and Information Act, which essentially classified health data as sensitive personal data simply because the harm done if you leak health data publicly can be quite massive to the individual whose data has been leaked. So you have sensitive personal data as a legacy piece of legislation. And then you have two very, very important pieces of legislation, the ones that I mentioned right now. One is your Digital Personal Data Protection Bill, and then you have your Digital India Act. Now, I must say, both of these pieces of legislation aren't laws yet. The Data Protection Bill is only out for consultation and will be presented on the floors of Parliament soon. The Digital India Act is just out for consultation. So both of these pieces of legislation, they aren't laws yet, but we will have to inevitably comply. Everybody in the healthcare ecosystem, everybody in the digital ecosystem in India will have to inevitably comply with these pieces of legislation, and that's the reason why I'm bringing it up right now and throwing out some of these key principles. So one of the key sort of pointers to keep in mind while thinking about the Digital Personal Data Protection Bill is who is a data fiduciary, right? So very simply, data fiduciary, again, legal term, is any entity that collects the data of an individual, right? If you collect personal data of an individual, then you are considered a data fiduciary. And if you are classified as a data fiduciary, which all healthcare service providers will be, you will have some compliance penalties and compliance challenges that come along with it, right? Now, because healthcare or healthcare entities, healthcare service providers collect sensitive personal data, they're also called significant data fiduciaries. So while you have the general compliance of a data fiduciary, that is to protect the data, make sure that the data is not leaked, make sure that the data is accurate, all cybersecurity measures, etc., are put in place, so the standard compliance requirements, you also have some additional compliance requirements simply because you are a significant data fiduciary and you collect sensitive personal data. So an added compliance, for example, I'm sure the IT team here knows this, is that you have to hire somebody called a DPO, a data protection officer. So he is an independent sort of auditor kind of person that sits with the IT team, sits with the IT manager, and if you have an internal CIO, to manage your data systems. And it's an independent role, and they report directly to the chair or the board or whatever the system of governance in the organization is. So that's an added compliance requirement, for example. So this is just one. There are many. I'm not going to go into the details of it and take a law lecture, but that's one of the requirements that you have. The other is, and this is something that will maybe throw some jitters in the room, is that one of the penalties for non-compliance, in case you don't comply with this particular piece of parent legislation, is that there's a 5 crore civil penalty. Right? Back in the day, it used to be a criminal penalty also. So whoever's in charge could be taken and put in prison, but now that has been taken away from the legislation, thankfully. But there is a 5 crore civil penalty in case of non-compliance with this parent regulation. Also, with the Digital India Act, it has just come out for consultation, so I'm not in the habit of speculating, so I won't speculate on what is to be expected, but essentially all of the principles of the IT Act will continue to exist with some added level of compliance. Right, so we'll talk about how exactly compliance works a little bit later, but I'm just throwing out that these are the parent legislations that we'll have to keep in mind while thinking of health data management. Then, of course, you have your regulators. So these are the entities that regulate how exactly an entity manages their in-house data. You have the Data Protection Authority. It is given powers through the Data Protection Bill, so the legislation gives it power, it empowers the body, called the Data Protection Authority. That is the organization that essentially can come and fine you the 5 crores that I was talking about earlier. In case they find you in non-compliance, they can come and fine you that 5 crores. Then obviously, because we're the healthcare sector, we have the National Health the National Health Authority, sorry, I've written association, my mistake, which is broadly now being a little bit realigned as the Ayushman Bharat Digital Mission. So we're expecting that there will be a subordinate regulator that is formed under the NHA that will look after health data management. And then you have the adjudicating authority that is expected to come out through the Digital India Act. This already exists. The IT Act already has an adjudicating authority and an adjudicating board. A version of that will continue to exist under the Digital India Act. So these are the regulators. So any policy, any movement, any document that comes out of these 3 regulators essentially will dictate how health data management standards and health data management generally in your organization will change over time. Now you have some sector-specific regulations, like when I was talking about legislations earlier, as I said, they're sector agnostic, applies to all sectors across the board. Sectoral regulations are made by the regulator for the sector. So they apply only to that particular sector. So HIPAA, for example, in the US is a sector-specific regulation. Now, we are expected to have 2 pieces of sectoral regulation coming out. Again, these are draft versions of the regulation or policy. We don't have an official one presented as an official policy yet. We have 2 very important ones. Both came out last year. We have the ABDM health management policy and the health data retention policy, both of which are expected to become regulations as we go forward, expecting them to kick into action in no less than a year. Within the period of, let's say, 9 months, we should see these regulations in action, and compliance will then be charged. So some of the key things, again, I'm not going to go over this very densely written slide. The health data, the health management policy that came out through ABDM talks about a couple of things. Again, we saw the ABDM architecture early on in the day. Essentially, the idea is to onboard other healthcare service providers and healthcare practitioners onto that ecosystem so that it stabilizes how health data is regulated in the country. Now, obviously, if you're onboarded as part of the system, then you're given a unique identifier ID. Every practitioner, every healthcare service provider, every patient, like how you have UPI, you have a UHI ID that's going to be given to you. So everybody gets onboarded onto this standardized system that's easier to govern. So we have policies under that. Not too much attention has to be paid to how exactly the regulations come out, because most of them will map or will follow under the stead of the data protection bill. So if you follow the data protection bill in its principles, you should easily comply with what is expected out of the ABDM policy. You also have the health data retention policy. It's a fairly large piece of policy, it's a large piece of regulation, but I'm going to cheat really quickly and tell you the essence of it. As a health service provider, if you're able to store the data for healthcare data for up to 10 years, you're in the clear. That's essentially what that long piece of regulation is trying to do. All right, so in our space, given how much we work with, the healthcare ecosystem, something that we've learned, not just healthcare, just with the BFSI sector, which is the banking and financial services sector, and the insurance sector, something that we've learned consistently is that regulators are temperamental, right? They change over time, laws change over time, and it becomes very, very difficult for a practitioner or a healthcare service provider or any service provider to comply with these ever-changing pieces of laws and ever-changing pieces of regulations. It's a very, very difficult process to keep doing to yourself. It's resource exhaustive. It's really expensive to do in-house. It's an unnecessary hassle. So the way we look at it is that we look at pieces of global principles and global legislation, and we draw out some key principles of, let's say, health data protection. These are the key principles that you need to follow. And if you follow these key principles, you're pretty much okay. You're pretty much in compliance, right? Instead of following particular clauses of regulation, which might get challenging because you have to keep changing things over time, broadly, if you're able to comply with these principles, you're in pretty good hands. So for the purposes of health data protection, we have some key principles that I want to touch on. One is accurate and proportional data collection. Accurate is fairly straightforward. Make sure that the information that you're collecting is right. Make sure that you ask the patient again and again if the information that they're providing is accurate. Because the liability in case, even if they provide inaccurate information, is on you, unfortunately. So you want to make sure that you're collecting accurate information. Proportional data collection. Now, as one of the speakers mentioned earlier, we're very greedy for data. So we generally tend to collect as much data as you can give us, right? Because we think that we're going to use it for research analytics later on. Realistically, not true. We just store it in hordes, and then there's a cybersecurity issue a couple of weeks down the line. So what you want to do is collect only the information that is needed to service a particular function. So if you feel like you need this for a particular diagnostic, then you collect that much information. That's it. You don't collect any more information than necessary. So you have accurate and proportional data collection. Effective communication. Now again, one of the speakers earlier spoke about notice and consent. So as I think, again, as lawyers and policy practitioners, we're in the habit of going on and on and on when we write a document. And I think it gives us a little bit of a thrill as well, to use some words that other people might not know. So we write large pieces of text, and we make it very, very confusing for a reader. I don't think any of us has actually read a terms of service policy from the beginning to the end, a privacy policy. None of us have done it. Lawyers don't do it. It's something that nobody does, right? So effective communication essentially is very simple. We want to take the policy that an organization is implementing it and make it as simple as possible for the reader to understand. So if you're collecting data for, let's say, diagnostics, you're collecting it to send them some flyers, let's say some advertisement, you're also telling them that this data is going to be stored for 10 years, and you're going to say, okay, these are the practitioners that are able to see your data. You can just write these in 5 points. You don't need to write a 20-page document and send it their way, and you can write it in very simple English. So that's another principle that we've been espousing for the past couple of years, is effective and very simple and straightforward communication. The next is informed patient consent. Especially in the healthcare ecosystem, a lot of the time, as I think Ms. Uma Nambiar was also mentioning, is this concept of implicit consent, right? At least in the data protection bill, something that we have to keep following back up on is informed consent and explicit consent. So when a user is consenting to something, we're asking them for their active consent. We're not presuming consent under any circumstance. So when their data is collected, you're asking them actively, are you sure you want to share this kind of data with us? Are you aware of the risks associated with collecting this kind of data? Are you okay with this in the long term, right? And if the patient makes an informed decision post that and says, yes, I know the risks, I understand why you're collecting my data and I'm okay with it, then that is informed, active, explicit consent. Then you have use or disclosure of patient information. Obviously, you want to make sure that the sources with which you are disclosing information is safe. You want to make sure that they're part of the ecosystem and they have cybersecurity best practices. So a lot of organizations will expect through contracts that we sign that if you don't have this standard of cybersecurity, we're not sharing our data with you, right? So if you have this standard of cybersecurity, you have this standard of data protection, you have a DPO in-house, you have a grievance redressal officer, you meet all of our criterion, then okay, we'll share our data with you, otherwise we're not doing it. So you're protecting your own patient's privacy and security by ensuring that you're calculating who you're sharing your data with. Securing patient information, again, having cybersecurity best practices is the idea behind that. Enabling access and correction. Now, for a user who's probably a patient with you now and 10 years down the line wants to collect back his data, he should be able to do this with a considerable degree of ease. He shouldn't have to jump through many hoops in order to understand where his data is, and his data doesn't exist in correct formats, etc. So you want to be able to give the data to the individual who requests it in a timely manner. This is also part of most compliance. In fact, most laws will dictate that you do this. And in case they feel that the data that they've given at a earlier period in time was wrong and they want to correct it, they should be able to do so retrospectively. And the last, of course, is maintaining patient privacy and anonymity. This is not something that I have to re-emphasize to the folks in this room, but again, that's a key privacy principle that we wanted to highlight. So these are some standard principles that underlie all data protection legislations across the country, across the world. So if you're able to comply with these broad level principles and build that into the fabric of your organization in terms of how people look, your organizers and people look at privacy and security, as well as you're able to implement this in terms of your technical interventions like privacy enhancing tools, which is PETs, or privacy by design, you're doing a fairly decent job at ensuring patient privacy. So I don't know if you've had a chance to look over your kit. You should have also received a document that looks like this, because we realized that while we're able to give individual advice to our members, a lot of the times folks that are not our members get left out of the ecosystem. So we created something like this, which is a public access document. A print version of it is also available in your kit. To essentially, the point of this document is to synthesize the information that I just mentioned. It does so by looking at different examples that practitioners might face in their everyday sort of life. Yeah, so that's about it. That's my presentation. In case of any questions, I'm happy to take it. Do we have time? Okay.
Thank you for that. I think we can take 1 or 2 questions before the break, if there's any.
Hello. Thank you for this great talk. Being a European, of course, I'm very much into the GDPR and similar legislation. And there's been a bit of a backlash in Europe about this data protection activity, right? Which is very similar to what you showed in India. And it has to do with the fact that GDPR caused nobody to share data anymore, right? It stopped sharing because all the protection, nobody could do it. So now, and it's centered also on the consent that you mentioned, it is actually extremely hard to explain to a patient, especially perhaps in a less educated or any sense, what the risks are of us sharing their data. Because what are those? I don't think we even know what those risks are, right? So in Europe, with the European Health Data Space legislation, it's now being stipulated what shall not be done with data, right? And the number one is you shall not use data against that person. Yeah. No, you cannot do a decision that's detrimental to that person. And there are 10 other rules, right? Which kind of lays the burden on us again, as hospitals, to protect the patient, because we probably can know somewhat what the data will be used for if it's detrimental, but the patient cannot, right? So they sign away the privacy statement. Is India also looking for just setting some ground rules in the sense that this shall not be done with data?
No, I don't think India is going to have a negative list of what you can't do, because I think there's also generally, I'm sure this is something that you might have also noticed, that there's India's data protection bill is taking a heavy turn away from GDPR, kind of aligning more with the APAC regulations. So in that sense, we are actively trying to stay away from some of the stipulated sort of actions that the GDPR has taken over time. But I don't think a negative list of what can't be done or a list for healthcare service providers will come out. But what will end up happening is these principles that I mentioned will kind of just become enshrined and codified into the regulation itself, and sort of, it will be way more paternalistic than the GDPR, if I think that answers your question. It won't be as light touch as the GDPR is at the moment, way more paternalistic than what it is.
Dr. Vinay from CMC. Often to understand and to comply with the regulation, there's a large cost, and that cost will be passed on to the patient. How does this feature when policymakers make these regulations?
At least in the context or the temperament that the ministry and the NHA has taken in terms of regulation over the past couple of years, is that it's a patient-centric legislation. It's a patient-centric regulation. So if there is a minor cost, as they see it, I'm not going to litigate on that, if there is a minor cost that is being passed on to the healthcare service provider, then that's not something that's going to be as much of a consideration as it would be for the ultimate citizen. Because I think in their equation, if equity has to be reached, then at some point you have to make the healthcare service provider pay a little bit more. So in terms of how policy is drafted, this is obviously a consideration, but it's not as heavy-handed as it would be from the perspective of delivering care to a particular user.